Okay, so we can have one question in the meantime, but what she's talked about, that just clearing the media is one of the things. To keep it clear is what you have to do, and keep giving glasses and keep focusing the light. Let me count the number of people sitting here. Himanshu is 1 to 50, 51 and 52. 52 kule. Your ARC guy is here. So your 52nd number, 52 kule. Okay, now, so we'll discuss everything later. Now, how do you decide what lens power you want to put in the eye? I mean, okay. So one is the target refraction, the other is the myopic shift, right? So these are the two things. If you know about these ones, I think you'll sail through. So is the small adult infant eye as just a small adult eye? The answer is no, because if you see the cornea, it's as steep as about 52 at the birth, and the axial length is about 17. And over a period, the cornea keeps going flatter and the axial length is increasing. So this is what is called emetropiization. So all the old textbooks which you say that all the pediatric age group kids are hyperopic, should be burnt and thrown out of the window, because they are not. So I'll be just showing you the study from Gordon et al. In which they have talked about how they did the study, and we'll just go into details on that. So axial length changes, keratometry changes. Infant sclera is half as thick as the adults, so please do not do any SFIOLs in these ones until unless the kid is about 7, 8, 9, 10 years. And even if it's 10 years old and a Marfan syndrome or a Beal syndrome in which the sclera is thinned out, please don't do a scleral fixated in these ones. Iris is the only option in these ones. And you can put a retro fixated iris, or you can do an anterior foreclaws, which we recently started doing. So obviously the eye grows, but how much can anybody predict? So let's find out. Why should we go into the undercorrection? Why can't we give whatever the emetropic power is there and then, and let's get over with it and keep giving the glasses? So what we realized that if you keep doing that, you might have the myopia, which might be very, very high. Initially, it's less amblyopigenic, very good, but eventually you might have to change the lens in all patients because all these eyes will grow. I'm talking about the eyes which are 1 month old, 3 months, 6 months, till 2 years. The earlier good old books used to say don't put any lenses in less than 2 years of age. Even the IATA studies say so. But since we started doing these surgeries for the last about 15, 20 years, now we realize that this is the way to go, because most of the phakic lenses will not be effective. And parents who are from the poor strata, they might pick up one pair of glass, and once it breaks, they might buy one more. And after that, they'll stop using the glasses. So as much correction you do with the IOLs, I think you should do it if you can put it safely into the eyes. Okay. So the advantage is that if you keep them emetropic, you will have less amblyopia at that during that period, maybe a month or 6 months. But eventually, this will start growing up. But how much it's going to grow, let's see. Look at that. So basically, a moving target versus a still target. In adult cataract, everything is grown up. Excellent keratometry you get in Eureka, you got a power. You might still have an error of a plus 0.5, plus minus. Okay. In the pediatric, it doesn't work that way because the axial length is changing, your keratometry is changing. So whatever formula you use, everything's going to fall flat. So let's see how we do. Now, this was the study I was talking about. So kids, when they're born, they have a normal refractive error about 0.4, plus 0.4 to a minus 0.5. And that's about it. They're not plus 5, plus 6, plus 7. If they were like that, why wouldn't every kid born be wearing a glasses? Because they can see for near. As long as they can see for near, that's good enough to develop the retinal function and everything at the back, at the optic tract. So they're not hyperopic. So how did we come to this? And if I ask you a question, what is the A constant of your own crystalline lens? Can anybody tell me? Because you have your keratometry, you have your axial length. So all these IOL companies, they give you A constant for the lens. If you try to back calculate, your keratometry, your A constant will be about 116.4, which is what was seen in the case with Gordon's. So they say that in the first phase, it's an early phase, which is fast growth for the axial length, and then it goes slow, and then it almost stabilizes, right? So let's see what happens. So if you look at this data, I have a pointer here, I'll use this one. So axial length at the age of 30 to 35 weeks. So what these people did, they went to the nursery where the kids are born, and they took the consent from the parents, and they put a drop of cyclopentolate in each of these kids and did the axial length keratometry refraction. all the examinations, right? But they did a consented, otherwise it would have been not the correct thing to do. So they realized the exit length at the age of 35 weeks is 15.1 plus minus 0.09, which is a very small eye. And you see the keratometry, it's about 53.5, so it's very steep. Now, these are actual patients in which they did it. And by the time they realized when the kid becomes about 3 years old, it's 23.5 at the age of 10 to 15 years and goes to 43.5 as a keratometry. So it's one is increasing, the other is going down. But if you see the net, it's the refractive error stays more or less the same. So you see the refractive error starting from the beginning. So it could be -1 plus 0.3 all the way to down. So this, except one diopter, there's not much of a change in these ones. Is that clear? So it's the emmetropization. The eye is increasing in exit length and keratometry going flat with the lens in the center and the cornea also a refractive body. So what happens if you remove the lens in these patients? So now all the equation has been thrown out now because the lens is not there, so focus is not there, there's a blur. So the peripheral blur can cause havoc. All these things can cause growth in the eye or it can cause retardation of the eye. So if you see all the studies, they say there's an increase in the exit length in these patients when the patients don't wear glasses. If they are undercorrected and don't wear glasses, the eye is going to go much more than proportion than what they expect in a normal population. So, okay. This gentleman, McClatchy, made a formula to have IOL power calculation, that you take the age and the refractive error and you press a button, you get the power. It fell flat because it doesn't work. It doesn't work in pediatric age group. You can't predict which eye is going to grow how much. So let's see what is the growth now. If you look at the growth, I think the best paper there is this one in which Wilson et al. They found out that in the first 6 months, every month there's a growth of 0.62 millimeter. So that means 0.6 into 6 becomes 3.6. So from birth till 6 months, the eye has grown by 6 millimeters, which if you take all the SRK and all these formulas into 2.5, it goes a huge power. So there is a definitely shift. The younger the patient, the more undercorrection you have to do. I'll tell you what formula we follow. And after 6 months to 18 months, it's moderate, about 0.19 per month. And after 1.5 to 2 years, it's again changing, but it's very gradual. So there's one study in which they used, at the age of 6 years onwards, they used a normal, no undercorrection, and they found it doesn't make any difference if you do undercorrection or not. All right. So what are the other factors? What age have you operated this child first? Whether you put in an IOL or is it a aphakic patient? Because aphakic patient, even if they wear glasses, the image quality in the periphery is not going to be the same because all the prismatic effect from the pincushion from the aphakic lenses. So that's not a way to go. So they might grow faster and much more. There was a study in which they used rigid versus foldable lenses, but rigid everybody stopped using, so I think there's no point in discussing that. Unilateral versus bilateral is a big issue because unilateral surgeries you do at an early age, and if you don't give them glasses, not occlusion treatment, they might grow much more than the other eye and may become longer than the other eye. So rehabilitation, which Aishwarya said is very important. Intraocular pressure has to be measured. The eyes in which there was intraocular pressure high, I did a study with my glaucoma colleague, Dr. Vinay Gupta, in which we picked up these patients with the open angle glaucoma in the children. We realized that it was a problem in the first few patients. We didn't know what power we were using. There was all going haywire. We had to exchange the lenses. Gradually, we realized that the bigger the eye, the more undercorrection you need to do. And if your pressure can't be controlled, even that much is not adequate. It will keep changing with the pressure going up and down. So it's a very, very crazy thing to do. And the most thing like a genetics, if the patient is a Caucasian, Indian, Asian, I think it'll make a difference. So whatever is happening in your population is your duty to see these patients for follow-up. And every time they come, you do excellent keratometry and refraction and keep holding to your data. In 10 years, you know what is happening in your patient because there's no shortcut to that. All right, so these are the studies which talk about what is the growth like. I think I'll skip from that. And we have about 15 minutes to go. Okay, so there was a questionnaire which was sent by Ed Wilson to the adult cataract surgeons who was doing pediatric surgeries and to the group of APOS, for the pediatric ophthalmology specialist group. And they found out that all the people from the APOS, which is the pediatric ophthalmologist group, they were doing, at 6 months, they're doing high hypertropia checkup, residual. So you're in high hyperopia, moderate hyperopia, and low hyperopia. So depending on the age, the higher the age, the low hyperopia is what you anticipate in these patients. Okay, so lenses I'll skip. Unilateral is always more associated with excessive elongation if you don't follow this patient properly. So this is what I was talking earlier. All these gentlemen in the past, Dahan and Prost, they used to do lots of undercorrection, more undercorrection, which in our eyes we realize that it doesn't help. So their eye growth is faster, ours is not growing that much. So what we come to, and this is another formula by NBRD in which it's very simple. Age of the patient plus refraction you want should be 7. It's a very tricky one, but by and large, if your exit length and keratometry are finding in the middle of the Gaussian curve, plus minus 2 standard deviation, you can get away with that. So this is a very good formula. Rather than putting too many complications to it, you can follow this one. Other one, we did a study at the RP Center in which we took 4-5 groups, less than 6 months of age, 6 to 12, 12 to 2 years, 2 years to 5 years, and 5 years and above. So all these groups has been now followed by at least for a year and a half now, and we've seen that the 6 months has become 2 years. So we got a good follow-up of these patients with exit length keratometry and whatever error we got. So what we found out exit length was mean exit length is there and then the keratometer on the side. And this is the power which we put. In these patients, less than 6 months, we put about 25.5, which was 20% undercorrection. 6 to 12 was 12.5. And then from this, we came out and we used the SRK2 formula. From this, we derived one formula which says that if it's more than 5 years, there's no need to undercorrect. Whatever power you're getting, if it's say 22.23, you can take 0.25 less, whichever, because the lens is not available in a 0.25 jump. They are on 0.5 jumps only. So you can just go to the first. We got 15 minutes more discussion. So you can stop that. Yeah, thank you. So if it's 5 years, do 2%, and at 2 years, do 5%. Remember 2.5 plus 7. So it works well. Then less than 2 years, if it's 1 to 10 years, 10%, 1 to 2 years, 10% undercorrection works wonderfully well in most of the patients. 95% of patients will fall in that group and they're doing good. The problem 6 months to 1 year is a little tighter zone, but we realize that 15% is good. The moment you touch 3 to 6 months, you have to do 20%. And that is still okay because we're getting higher hyperopia. We aim at about plus 8 to plus 10 in the glasses. That's good enough for them. But if it's less than 3 months, especially a unilateral cataract, you still have to put IOL because if your patient is not on contact lenses and unilateral FAK glasses, they're not going to help you anyway. So this is very high. We are looking at these patients right now, and we have explanted about exchange about 6, 7, 8 patients by now over the last 20, 25 years. And those are the one in which the surgery was done earlier, and they've gone to about minus 12 is what they got, and we exchanged the lenses. And amongst them, I think one patient, again, eye grew, and we had to take the lens out again for minus 7. So that means from the birth till the age, he was 17, 18, 2 exchanges, and both were about a minus 11 and minus 8, so minus 19. So that's a huge shift, huge shift in that one. So this is the formula which we at RP Center we're using in the center. So if you talk about the newer gimmicks and all, which you talk about adults and ELP, in pediatric you can't decide the ELP of the patient. How do you know where the lens is going to park? If your vitrectomy is not a standard vitrectomy, if you've done more vitrectomy, your lens will go a little posterior. If you've done less vitrectomy, it will come a little anterior. So you can't depend on the ELP as much in these ones. So that means you're not very clear. You have a gray zone, so you have to work out in the gray zone. If your post-op error is a plus minus 2 diopter on the first day, I think you've done a good job. But still, I'll be more happy if it's a plus 2 rather than a minus 2. So we aim for the hyperopia undercorrection. That's what is the name of the game. Because minus 2, if you have, it's going to go up to minus 6, 7, 8. Or maybe if your occlusion is not given and the glass is not used, he might go to minus 17, minus 18. And then you can't control with the refractive corrections also. Even the LASIK won't work in that one. So you have to work up these patients properly. You have to insist that they follow whatever Aishwarya told them to do diligently. Okay. So I think we'll skip single piece is what you should do. Now, there's another thing. If you are putting a poor quality lens in the patient and you have a glistening which is happening in the adult, you do the surgery at the age of 50, the glistening develops by 10 years, 60 years, that's fine. But the child who's going to live for the next 80, 90 years, please be very diligent in picking up the lenses. It's best not to put a poor quality lens in the patient. Rather, it's better to leave them fake rather than putting a poor quality lens in these ones. So we can't afford to have any glistening. So this was one study in which they found out the 2 eyes in which pediatric lens they had to exchange because of the glistening. All right, so there's a bag in the lens technique by Mary Thesigan, but that lens has its own problems because the lens will be centered on the rexes which you create. So the ankle kappa is not possible in that one. Whereas in a lens in the bag, you make a rhexis, and you put the lens, even if your rhexis is eccentric, your lens is going to go into the bag and open up, right? It's going to follow the bag. Whereas if you have shifted both the rhexis off center and you implanted the lens stuck to that, it's never going to come into the center. All right, Dr. Leela? Because if your rhexis are not in the center, lens is not going to stay in the center as good as that. Okay, so now let's see what this gentleman has learned. So this is what you need to do. You have to shoot the target. You see there's a target is moving, the eye is growing, and he misses the bird, right? So maybe after attending this symposia, and you've taken the exit length into consideration, you've taken the ethnicity of the patient, intraocular pressure, the lens where you put the lens, and then you try to shoot. If you notice here, you'll shoot the thing. Yeah, but that's not a one bullet which is shooting. So there are multiple bullets. That means there's so many options you have to shoot the target. So even if you're missing that, that means you're quite off the target. So even if you have a target which is moving and you have a multiple bullets, so you can have a plus minus diopter. So I said you can have a +2, +3, +4. That's still okay because they'll start growing into it, and that's what you get it. So I think we'll close it, and we are open to questions now. We got 15 minutes clear, and thank you very much for being such a nice audience. And we got Pachpan Kule now. We got 4 more people. Okay, the questions, please. Good.
Good evening, sir.
Can you tell who you are first, from where you are, and then ask the question?
I'm Dr. Sujit. I'm practicing in Hyderabad.
Okay, great.
Does the same normogram apply for cases of traumatic cataract, say 3 or 4-year-old with a unilateral trauma?
Yeah.
So do we need to do bang-on correction or under correction?
Perfect. I think that's a great question. Okay, so traumatic is another ballgame altogether. So the eyes which are traumatic will not grow as much as the other eyes. So if there's a change in the, what do you call the equilibrium inside. So you can go under correction, but not that. Whenever you have a unilateral, always do less under correction, right? So if you do less under correction, this one, so if you're getting, for the same age, if you're doing, say, under correction by 3 diopters, here you go by 1 diopter, 1.5 diopters. So go half of that. That'll be good. And in the traumatic, if you have a problem, you can because anterior capsule, posterior capsule might not be intact, so you can put a 3-piece in this patient if both the capsules are stuck together, make an opening in the center and do a capture. In a bigger kid, you can do a capture because the lens doesn't have to be changed later on. But in the younger kids, don't do a capture with a 3-piece because you might have to remove this lens. So always keep that option open. Yeah.
Recently, there is increase in myopic shift in children. We are seeing a lot.
Yeah. Okay.
Because of the gadget usage and all.
Yeah.
So does this normogram, say after 5 years, does it still hold?
Yeah, this normogram we've been following for quite some time now, I think. And before we published this work, I was using that for around 20 years now. But whenever we try doing more under correction, like Prost and so we always had even after the age of 16 years, they still were hyperopic. So that's the problem, because hyperopic vision is not taken as well as a myopic vision. Yeah. So you do it in your patient, and please come out and we'll discuss.
Sure, sir.
One question.
Sure.
In place of your PCCC, then putting the IOL, can we go with a vitrector behind the IOL, then do with the vitrectomy? Can you take up the posterior capsule and do the vitrectomy both in one setting?
Yeah, that can be done, but it would be better to do it from a pars plana route, or even from the anterior route also we can go behind and do a vitrectomy under the IOL. But it's usually better if we do a PCCC with an IOL if everything is clean. That usually gives a better and more well-centered IOL.
Yeah, when you do a vitrectomy after putting the lens, you don't know how you've done all around 360, right? But whereas what they showed you was you do from one side and change the hand and do from the other side and let it fall back all the side equally. So your ELP, effective lens position, will be much better here, and chances of VO are less. So if you cut from the back, you have to do a bigger vitrectomy, so you might not be equal on both the sides. So you might have a cataract coming from one side. And it's not difficult. I don't know why you people are scared. PCC is much easier than ACCC. ACCC is the one which is like a dome up, so it runs off. PCC hardly ever runs unless you overfill the bag and you push the bag so much down that it's a reverse top of the hill phenomena. So it's like a dome up versus dome down, and you give a nick, it opens posteriorly, the nick, and then you have a problem controlling it. Okay, so what she showed you was that you let the chamber go flat, let the posterior capsule actually go with the helon behind it, inject it, and make the posterior dome like anterior dome. So make it an anterior capsule curvature and do it. And she showed very well on the video.
Thank you.
Ma'am.
Just a question to Dr. Aishwarya.
Sure.
I don't know, we do some dioptic treatment for routine amblyopia, or more in an isometropic actually. How far it's effective, because most of the unilateral cataracts are refractory, and how soon, and do you have experience in dioptic treatment?
Ma'am, we've started studies in RPC for the same, but dioptic as a standalone treatment has been not effective.
Not standalone.
As an adjunct to occlusion therapy, yes, it has had more advantage. It has moved from a category of a severe amblyopia to a moderate amblyopia in cases which was not refractory to just occlusion therapy. Dioptic treatment we have followed for 6 months and seen a change in the amount of visual acuity that was there, and especially fixation in younger children also.
Okay, thank you.
Thank you, ma'am.
Is there a question? Lovely, come.
Good afternoon, sir. I am a junior resident, third in Rio, Allahabad. I'm actually doing a thesis on this, and I made a basis of your study in RP Center that you did on the pediatric age group. So I just wanted to know that before you concluded about the study in how much undercorrection amount of lenses that you're putting, I just wanted to know before the study that you had done, what was the undercorrection that you were taking for the pediatric age group, after, like in which you were putting the IOLs? Like how much undercorrection were you doing for age groups? Like after 1 year, were you doing 10% undercorrection?
Yeah. So yeah, okay. So we were going 10 to 12% there. Okay. At one year, 12 months means 12% what we're doing. Yeah. Now we even reduced that by 2% further now. So it was not that tightly moderated. Now, in fact, it's become much tighter.
Okay.
So initially we had little dingers, but we had about a +3, +4. So you go in the term of hyperopia. So if you can have high hyperopia for 6 months group, and from 1 year till 2 years, if you can have a moderate hyperopia, and after that, if you can have a mild hyperopia, I think you will be good. So you can use the antibodies principle 7. We used to use that 7 formula. It worked pretty well, actually.
Okay. Thank you so much. Thank you, sir.
Welcome. And all the best for the thesis. If you have any queries, these guys are there. Otherwise, you can mail me. We can help you out. Perfect. Is there a question, or he's going out? No, he's going for the next session. I just asked one question to Ayush. Ayush, how important is the examination and anesthesia according to you?
So examination and anesthesia are very comprehensive evaluation, because we can't really afford putting the child under general anesthesia every time. So nothing should be missed, especially like in cases of traumatic cataracts. We can say if the child is under anesthesia, we should do as much as possible. For example, gonioscopy, intraoperative gonioscopy should be done for children with traumatic cataracts to look for any angle recession. Then, as I mentioned in my slides, even intraocular pressure assessment preoperatively is very essential, since if there is already preoperatively there are high pressures that has to be managed for optimal outcomes. So like I said, we cannot afford to give GA every time, so we have to be very meticulous to not to miss any particular investigation during our time under anesthesia.
Yeah, and I would like to add on that once you take a congenital cataract, traumatic is a different ballgame altogether. So if you have a congenital cataract, it's a bilateral, normally the eye is going to be normal, healthy eye, good size. Unilateral cataracts, always the pathologies in the eye. So if you're doing a UA for the unilateral eye, please go into all the details. You should have an indirect ready, you should have a UVM ready, you should have an ultrasound ready in case you want to do it again on the table. You have to do the keratometry, everything again, and be ready with the camera. And if you have, I think, how many of you have UVM with you? Okay. Oh, that's not bad. Because last time when I asked, nobody had UVM for the pediatric. So this is dedicated. We have one dedicated to pediatric. And the second thing which on the table in the cataract surgery you can do is, you can put in a ILU in the eye and put a wide angle on the top So we have recorded the pictures of the fundus of these babies who are from 1 month till 10 years of age, and nobody had seen their retinas before. This kid is born with a ROP, and nobody could give an injection, and it developed, and there was a cataract. So we cleared the cataract. At the same time, we did with the ELU. So ELU doesn't have to go into the vitreous all the way. Once you take the cortex out and your posterior capsule is clear, you can just go over there, and the chandelier effect, you can actually take the images very well. So we keep the images of all. So that we've been doing for the last, I think, 3-4 years now. So we have gone where nobody had gone earlier. So if you have a cupping which was not there, and the patient comes for follow-up and you pick up a cupping, that means something has gone wrong in this patient in between. So these are the patients. So I think you can't take this patient lightly, because each patient is a potential citizen who's going to live for next 80, 90 years. So nothing which is short here. So whatever you do, please do over investigations on the table once the patient's under, rather than leaving something away. And whenever you see one eye in a traumatic or any other patient, please always assess the other eye, because there could be a refractive error there could be a problem in the retina which is not seen, because one eye is traumatic is fine, but what about the other eye? So many times we get the patient with one eye cataract, the other eye vision is also poor because parents never got the glasses. So please, for God's sake, do refraction for the normal eye also, and look into the retina, especially if the child is on the anesthesia EUA, please dilate both eyes and see. Okay? And if there are no more questions, I think I'll thank the panel. And these kids have done a wonderful job and made me proud. So thank you very much, everybody, for coming. And